Hello. In this part of Advancing Bronchiectasis Awareness and Education video series, I'd like to address the topic of management of bronchiectasis exacerbations. I'd like to start with an exacerbation definition. An international consensus panel has recently published criteria primarily for clinical studies, but also very useful in clinical practice. It generally involves an increase in symptoms of 3 or more, plus a change in therapy that generally involves antibiotics, but not always. Those symptoms that either develop or increase in severity include cough, sputum volume and or consistency, sputum purulence, breathlessness and or exercise tolerance decrease, fatigue and or malaise, and hemoptysis. Once we have patients with bronchiectasis exacerbation, we again fall back on this historical paradigm of the vicious cycle, and in this case, begin to address an acute bacterial infection. By doing so, we need to be mindful that the airways are not sterile areas. In fact, there's a wide range of pathogens present at baseline and reflective of those pathogens in our environment. Those organisms include, but are not limited to, bacteria, fungi, and mycobacteria. We understand that this microbiome or diversity of organisms within our airway that normally is present does change as bronchiectasis worsens. When we think about our approach then to addressing what may be the precipitating cause of a bronchiectasis with respect to infection, we have to be mindful, as many of us are, of antimicrobial stewardship. And we need to, one, is to select the optimal antibiotic regimen. We want to minimize toxicity to patients, and more importantly, minimize potential for development of drug resistance. This is an important concept in this at the global level. We understand that the impact of morbidity and mortality with resistant microbes is substantial, not only in the US, but globally as well. By being mindful of this and responsible stewards of antimicrobials, we can find that appropriate balance and try to minimize the resistance that has been observed with a number of pathogens over the past several decades. And resistance to Staph aureus, Enterococcus, Pseudomonas, Acinetobacter, and Candida have all been noted with increased antimicrobial use, not only for bronchiectasis, but for other infections as well. When we think about the approach to the patient with a bronchiectasis exacerbation, we can again rely and seek guidance by the European guidelines, which generally recommend an antimicrobial therapy course for approximately 14 days. The antimicrobials vary globally depending on previous microbiology and respiratory secretions and the severity of exacerbation. It's generally recommended that sputum analysis is obtained at the start of an exacerbation and may be helpful to guide choice of antibiotics in the event of an inadequate response to initial therapy. We may also consider shorter or longer courses of antibiotics in select instances based on clinical factors, previous exacerbation response, and patient preferences. In many instances, we generally encourage not only to have sputum at baseline to best inform us with respect to what may be appropriate during an exacerbation, but also sputum collection at the time of an exacerbation. It's also important to realize that airway clearance, an essential and critical component to any therapeutic plan on a long-term basis, may need to be modified, escalated during periods of exacerbation. And that involves from those options of not only regular aerobic activity, but active cycle breathing techniques, deep breathing, postural drainage, use of a positive expiratory valve such as a Arabica valve, a flutter valve, flute valve, or others. Nebulized hypertonic saline, either in 3% or 7% concentration, and use of a chest wall high frequency oscillation vest. And again, may escalate from what's used at maintenance, whether it be in frequency and or intensity, but the best airway clearance is the one that patients use and is effective. Not all two patients are the same. What works for one patient may not work for another patient and clearly needs to be individualized, not only during chronic management, but also during acute exacerbations. Education, advocacy, and empowerment remain imperative.